Let's cover potentially important topic, that is oxygen therapy. So the main goal of oxygen therapy is to maintain adequate tissue oxygenation while minimizing the cardiopulmonary work. The clinical objectives of oxygen therapy are correct documented or suspected hypoxemia, decrease the symptoms associated with chronic hypoxemia, that is decrease the work of breathing, if I want to put it into simple words, and ultimately decrease the workload hypoxemia imposes on the cardiopulmonary system. So the indications of O2 therapy are documented of hypoxemia as evidenced by PaO2 less than 60 mmHg or saturation less than 90 on room air. Partial pressure of oxygen or SaO2 below the desirable range for a specific clinical situation. For example, in COPD, usually they tolerate low saturations. So acute care situations in which hypoxemia is suspected, severe trauma, acute MI, and short-term therapy, that is post-anesthesia recovery. The need for oxygen therapy should be assessed by monitoring of ABG, that is PaO2 and saturation, and clinical assessment findings like cold clammy extremities, cyanosis, palpitations, or any kind of sweating. PaO2 as an indicator for oxygen therapy. 80 to 100 mm of HgPA partial pressure of oxygen is normal. 60 to 80 is cold clammy extremities. Less than 60 is cyanosis. Less than 40 will cause mental deficiency or delirium or memory loss. Less than 30 will cause bradycardia and cardiac arrest. PaO2 less than 60 is a strong indicator for oxygen therapy. Clinical assessment of hypoxia, mild to moderate and severe. Mild to moderate there will be restlessness, disorientation, lassitude, and headache. Whereas in severe there will be somnolence, confusion, impaired judgment, loss of coordination, and obtunded mental status. Cardiac will have tachycardia, mild hypertension, and peripheral vasoconstriction. Whereas in case of severe hypoxia there will be bradycardia, arrhythmia, and hypotension. Respiratory system, there will be dyspnea, tachypnea, and shallow and labored breathing. Whereas in case of severe, there will be increased dyspnea, tachypnea, possible bradypnea, and labored breathing in case of mild to moderate. Skin, there will be paleness, cold clammy extremities in case of mild to moderate hypoxia. In case of severe hypoxia, there will be cyanosis. So monitoring will be done by physical examination of clinical features of hypoxemia as described before, by pulse oximetry, ABG analysis for pH, PO2 and PCO2, and mixed venous blood oxygenation. So coming to O2 delivery devices, low performance devices, low flow, that is nasal cannula, nasal catheter, and transtracheal catheter. The reservoir system, variable performance device, it is reservoir cannula, simple face mask, partial rebreathing mask, non-rebreathing mask, and tracheostomy mask. High flow is venti mask, a venti mask, and aerosol mask and PPs with nebulizers. So these are random pictures I have taken from internet. Just pardon me for that. But my aim is to make you understand, to look at the images and get your image-based questions correct. So the nasal cannula, which we commonly use in our ICUs. So the amount of oxygen that you can give is 2 to 4 liters per minute by this nasal cannula. So this is a simple face mask. Here are the exhalation ports, and here is the oxygen inlet. So this is a non-rebreather mask, which we used commonly called as reservoir bag mask, when we used extensively during our COVID pandemics. So this is oxygen reservoir bag. This is inspiratory valve, which is unidirectional. This is oxygen line. This is oronasal face mask, and these are the expiration valves. Very importantly, this is a nasal catheter, where the catheter tip is placed behind the uvula. So nasal catheter is not same as the nasal cannula. They are different. So this is the Venturi mask. These are the Venturi masks, which are fitted like this here, which increase the FiO2 basically of oxygen. These are color coded depending on the oxygen percentage of oxygen they deliver. So coming to the color coding system, once again. Yeah, the blue color provides 24%, white color provides 28%, orange color provides 31%, yellow color provides 35% of FiO2. The red color provides 40% FiO2 and the green color provides the highest, which is the 60% of FiO2. This is very important. Complications of oxygen therapy or oxygen toxicity, depression of ventilation, retinopathy or prematurity, absorption atelectasis, and fire hazard. O2 toxicity primarily affects the lungs and the central nervous system. PO2 and X2 factors, it depends on partial pressure of oxygen and exposure time. CNS O2 toxicity is known as Paul-Bert effect. Very important MCQ. Occurs when breathing O2 pressure is greater than 1 atmosphere. It causes tremors, it causes twitching, and it causes convulsions. This is classically seen in hyperbaric oxygen therapy. So how much of the O2 is safe? 100% is not more than 12 hours, 80% not more than 24 hours, and 60% not more than 36 hours. Goal should be to use the lowest possible FiO2 compatible with adequate tissue oxygenation. Indications of 70 to 100% oxygen therapy. One is resuscitation, periods of acute cardiopulmonary instability, and transporting the patient. So oxygen is a drug. If when appropriately used, it is extremely beneficial, but when misused or abused, it is potentially harmful.